Thank you so much for having me, allowing me to come here. I had a great week of meeting with a few people and a chance to hear about some other projects that are happening at DGHI. So I'm excited to be here and share a little bit about what Winnie and I have worked on in the past few months, and I think it's some interesting results, and I think it brings up some additional interesting questions. So I'm excited to be here. So let's get started. I'll introduce myself a little bit more. My name is Nathan Smith, and I recently graduated with an MPH from George Washington University, and so that's what originally brought me out to Kenya. Was to do my thesis work there, and I was looking at some malaria knowledge levels amongst some women who were attending MCH clinics at Webuye Hospital, and so I kind of got to know the area well, and then had a chance to stay on and come work with DGHI this fall, and so my wife and I stayed in Kenya a little bit longer, so it's great. So today I'm going to present kind of two projects that we've been working on. One's more of an analysis of a data set, and then the other was a separate project, both in the same areas. And so it's preliminary data, and it hasn't been published yet, but we wanted to kind of share some of the initial findings and results and spark some discussion. So hopefully we can do that. And we're kind of looking, they're all focused around kind of this geographic analysis, some spatial analysis, and so I kind of titled my talk "Use of GIS to Characterize Households," and we're kind of looking at uptake of interventions. And so today we'll focus on malaria, but I'll touch on some ANC attendance and immunizations as well. So the area of work is just west of Eldoret. You see, here's the picture of Kenya, Nairobi, and Eldoret is here. And this is Webuye. It's actually Bungoma East District. And Webuye is here, down kind of in the south central. And so, farming and subsistence farming is a way of life. And there's a large sugarcane factory and some farms in the area, and so we're also just kind of getting out of the highlands and into kind of the lake region, and so malaria is actually endemic through most of the year. The season's quite long, and actually malaria accounts for about 20% of all hospital visits, and so it's important and kind of why we're looking at it in this area. So I want to set a little bit of the context and tell you two stories. One about the story of this closed dispensary, and then the story of this neighborhood chemist. And they kind of illustrate some of the work and why it's important for us, why some of these questions, and highlight some of these questions. And so we began looking at public health facilities in the area. And there's actually, in the Webuye area, there's about 20 public health facilities. And in Kenya, the levels of care go from dispensary to a health center to a sub-district hospital to a district hospital. And in theory, each location, some of the smaller levels of administrative units have at least one dispensary. And so people have somewhat close access. I think government wants at least 5 kilometers to the nearest health facility. And so we set up to kind of look at some of the health facilities in the area, where they're located. And so we found one that we heard that was closed. We heard that it was open, and so I wanted to go figure it out where some of these were at and kind of confirm their locations. So this is one that I went to visit, and it looks closed. But in talking with some neighbors, they said that it was actually opened once a month. And so once a month, a nurse comes out and opens it up for one day. So we're like, okay. So this is interesting because it kind of highlights this geographic factors of access to care. So in this area, people only had intermittent access to a close primary care facility, and in Kenya, dispensaries and health centers are some of the where immunizations are administered. ANC clinics and bed nets are distributed through these facilities. And so, so like I said, it kind of highlights that there's geographic differences in people's access to care. So some have close, some have to walk further. And so in this case, where a closed dispensary or only open once a month dispensary kind of highlights that difference that people have. And then we also know that in the case of fever treatment, people tend to self-treat or seek out a medicine shop or a chemist. And so we can see how maybe if a chemist is closer, that the closed dispensary highlights that push, to where someone might seek treatment at a chemist because it's closer. And so I'm gonna touch on the story of the neighborhood chemist a little bit later as we transition to the other project. But you can see that these kind of raises questions about geographic access to health services. Can we identify populations at risk because they're further away, or what characterizes these spatial components? And but we also wanted to kind of look at, is there like this neighborhood factor or a community factor where there's some type of spatial structure in where people live and their access. And we all wanted to do this in the context of uptake of preventative interventions, of bed nets, of ANC attendance, and immunizations. And so we began working with AMPATH's home-based counseling and testing program. And AMPATH is, if you don't know, is the academic model providing access to healthcare. And it's a partnership model, actually, between USAID, Moi University, a Kenyan university, Moi Teaching and Referral Hospital, and a consortium of American universities, which Duke is part of that consortium. And their home base, and so they have a 2 million person catchment area in Western Kenya, and one arm of AMPATH is their home base counseling and testing program. And so they go door to door, testing and collecting some additional information. And so the HCT program has been able to test over 500,000 people, and they've had tremendous success in actually seeing a 98% acceptance rate in testing. And so they have helped communities, whole communities, because they go through the whole community. The whole community knows their status. And so it's been a successful program. Now in the Webuye area, the HCT program just was launched this last year, and they were able to visit 46,000 households. And in this whole area, there's a population of about 185,000 people. And when they visit each household, they're collecting GPS location data, along with additional primary health indicators. And so, so this is kind of the data that we began working with. And here, this is a map of the same area, and these blue dots are the household points. But the points doesn't mean a whole lot in this map. And so we can't visualize where people, where there are dense areas or anything like that. And so using ArcGIS and using a kernel density function, we can make a cool map like this that shows the density of population. So we can see around Webuye that it's on the dense end. The green is the dense side, and white is zero or very low household population. And we're looking. This map is a density map of per 800 square meters, and so we looked at kind of an 800 square meter radius when we ran our density functions, and we thought this was a good distance in terms of what we see on the map is kind of what we think, what we know from being there. But also 800 square meters kind of gives us an idea of maybe an estimate for village level distances, and so we can kind of see densities and see where there's clustering. So all the variables we used came from this HCT collected data, and the variables we used, some were inherent in the data, and some were derived by us. We did some distance measurements of how close houses are to the nearest road or to the nearest health facility. And so in our analysis, we began kind of with these first density functions and kind of visualizing population density, visualizing characteristics of households. And then we ran some distance measurements and did some cluster and pattern analysis and fed that into some of our logistic regression that kind of predict some outcomes and look at factors on uptake. So here we have, we kind of began with our density maps and wanted to kind of visualize the household characteristics. And so here we have 3 maps of the main 3 primary health interventions we were looking at. We have bed nets here on the left, and these are 3 maps of incomplete uptake. And so households with no bed nets, and in the middle we have households with a defaulted immunized child. And what was interesting, we found that immunization was actually about 90, 95, 98% of the children had BCG immunization, but we found that there was quite a few that were missing their measles immunization, and so we defined households that had a child who hadn't had their measles by the age of 1, and measles is usually around 9 months. And so this is that density map. It's hard to compare these maps a little bit because they're at different scales, but it kind of gives a visualization of kind of the heterogeneity of the uptake. And then on the far right is households with pregnant women not attending ANC. And so yeah, this kind of is a visualization. But I want to kind of hone in on bed nets, and so we're going to kind of stick with looking at bed net ownership. And so we began to kind of think about a specific question. What kind of coverage has the local distribution mechanism? What kind of coverage has it led to? And so we began talking. We had some discussions with the District Ministry of Health in the area, and
sorry, no, I just the map here with the households with no bed nets. The density is that the density of households with no bed nets, or is that density of people?
Yeah. So these are absolute numbers, okay. and so the white corresponds to in areas of how like 0 to 10 households with no bed nets, and so like the green, these areas per 800 square meters, there are 100 households that are missing a bed net.
Okay.
Does that make sense? So whereas like if we look at this population density map, the white is 0 to 20, and so within this area there's 20 or less households per 800 square meters. And so this is just kind of looking at a density of households with no bed net. So we're only looking at households that don't have a bed net. Okay, so we had some discussions with the District Ministry of Health. What has been the distribution mechanism in this area for bed nets, and in Kenya and in this area, the distribution mechanism is through routine, government health facilities, through ANC clinics, and through immunization clinics. And so that's where bed nets are passed out. And in this area, in the last 3 years, there hasn't been any type of mass distribution campaigns. And so, bed nets, I think in general across countries, some countries focus on routine government health facilities distribution. Some focus on investing in lots of mass distribution campaigns, and some have focused on social marketing and through the private sector. And I think it brings up the debate of what is the best mechanism to achieve high and maintain high coverage. And so here we've been able to examine the coverage of routine distribution here. So we can say, since we know in the last 3 years, in 2008 and 2009, roughly 10,000 bed nets each year were distributed through ANC clinics and immunization clinics. And in 2010, roughly 20,000. And we're not looking at any influence of mass distribution campaigns in the area. And so we can say, what routine distribution has led to what kind of coverage. And so what we found is that only 21% of the households in this area actually owned at least one bed net. And this is just looking at bed nets within the household, not looking at the numbers of bed nets, the use of bed nets, or the type, whether it's treated or untreated. This is just the presence of any type of net. And so then on here is kind of the opposite of this map, is households owning at least one bed net. And this is just for a visualization, but you can see where there's areas of higher density and where there's maybe some voids where there's no households that even have a bed net. And I've overlaid the public health facilities in the area to kind of give an idea of where some of these locations where people access bed nets. So now, if within the kind of epidemiological context, we need to factor for the underlying population, because these absolute density measurements, we don't know a lot. I mean, this doesn't tell us that much other than a visualization of where they're located. And so what we need to do is factor for the underlying population. And so what we did is we took these two density surfaces and calculated a coverage percentage. So we took the households that owned a bed net over all households and kind of created a percent coverage of these 800 square meter zones. And so this map on the left, we categorize 4 different zones. So white corresponds to 0 to 10%, and pink corresponds to 10 to 30%, Yellow corresponds to 30 to 50%. And these are percentage coverage within that area. And green is 50 to 70%. So then what we took is we counted the number of households that lived within these areas, and in this pie chart over here you can see that 51%, over half the population, lived within areas of 10 to 30%. So only 10 to 30% of your community had owned bed nets. And you see that 77% had 30 or less. And it's interesting that no households were above, no areas were above 70%, which, when you think about the kind of recommended levels, are 80% coverage. And so, and 80%, that number comes from studies that have looked at, what point do we begin to see like a mass effect or herd immunity in terms of people who don't own bed nets. Are they covered by people who do own bed nets? So we can kind of begin to see that there's pockets, there's these clusters of a lot of households in that area own a bed net. And so why, kind of raises questions, what's different about these green areas? What characterizes these green areas? We also wanted to look at it in a kind of a statistical view, and we wanted to kind of run some pattern analysis of across the whole area. And so we kind of wanted, we know that populations and population densities cluster. They cluster around town centers, or people just don't live randomly distributed across an area. And so we wanted to evaluate, are owners of bed nets more clustered than the population density? And so one way to look at this is through a point pattern analysis. And there's a number of methods, but we chose to look at a multi-distance K function. So Ripley's K function is what it's called. And it's analysis of point patterns across a whole study area. And so here we ran K functions for both our case population of do you own a bed net and our underlying population, and took the difference to evaluate the difference between the underlying population. And so here, this is the difference curve. On the y-axis, we have the weighted K, our case population, and our unweighted K, which is our underlying population. And then this distance, so it's evaluated over a range of distances. And so we can see that between 50 meters and 700 meters, households with bed nets are more clustered, because it's above zero, so more clustered than the underlying population. And then as you get as you evaluate at larger distances, it goes below zero, and you're more dispersed than the underlying population. And so what this kind of tells us is that there's some type of spatial structure happening, that households with bed nets are more clustered than the underlying population. And so, but the only bad thing is that it's across the whole area, and so we don't know if the locations of these clusters. We don't know where anything about them. Just that it is happening. So we do have some type of structure happening with our data. And so one next step is to kind of look at the local variations, more of a second order analysis where you're evaluating a specified parameter of neighbors. And so in the interest of time, I'm not going to dive too much into the details of and the methods of these analyses. But I wanted to kind of show them because I think they're interesting in how we begin to think about some of these questions. And so this is preliminary data, and I think one thing with spatial data is the architecture of the data and the way it's set up plays a major role in what you obtain from the results. And so we're still kind of evaluating the relevance of some of these results, but we also see that that there is some patterns between the analyses, and so we're, I think, seeing that there might be some type of spatial structure, but might not be able to define it. But here, if we focus on these green circles on the left, the green are households. So this is a spatial scan statistic that's using a Poisson-based model to evaluate against the underlying population. And so the results have shown that these areas within this circle are statistically significant clusters of high uptake. And then on the black dots on these two maps over here are from Anslin's local Moran's index, which is a second order analysis that evaluates your neighbors and puts weight on what is the value of your neighbor. And so these black dots represent households that are near other households with a bed net. So it's high uptake next to a high uptake, and these are evaluated, and these are statistically significant. These two maps are, this is the search parameter is your 10 nearest neighbors, so those that are living closest, and then this is, we opened it up to a larger distance band. And so it's interesting to look at and to see that maybe there is some type of structure. It raises questions about the influence of your neighbors and how do we characterize community factors or neighbor factors in uptake of some of these preventative interventions. So we began to take that next step and so what are the characteristics of these households? So here we can describe we've described these households with chi-square testing, our univariate analysis, and then our multivariate analysis using some logistic regression whether or not a household owned a bed net. And so we can see here that women attending A and C were not more likely to be in a household with bed net. And then households with children were more likely to have a bed net. And then we also see that rural households were more likely to have a bed net than urban households. And then on the right, we see our strongest predictors stratified on urban and rural areas. And so numbers of children were strong, as we saw here, and they're strong in both. And then we also see our wealth indicators of any land owned and any animals owned were strong. And then some of the distance measurements of whether a hospital is the nearest or the distance to nearest road. I think the largest factors were in the rural areas where a health center is nearest was strong. But I think in general distance had a smaller effect, especially in the rural areas. We also, it was interesting from some of our cluster analysis, we thought, okay, maybe we can take our prediction scores, our this z-score that we can obtain from this analysis. And so can we run that in our logistic regression? And so here we see that neighbors in rural areas, neighbors that had a higher z-score, so and in the cluster analysis, a higher z-score meant you were more similar to your neighbor. And we see that in rural areas they're nearly twice as likely if your neighbor owned a bednet. So bednets were most correlated with wealth, and distance shed some kind of light on the spatial component, but we are kind of limited on the number of variables that we can explore based on what was collected. And so we also kind of need to count for variations of, we're only looking at bednet ownership, not looking at use. We also, this is self-reported ownership, and so which might be a little bit lower. They might have responded based on receiving a bednet. So to kind of highlight what we've learned so far is that the wealth indicators are strong. We see that the type of facility is greater than the distance to the facility, which raises some questions about about whether the distribution mechanism is working through some facilities, but maybe not others. And we also see that there is some type of spatial component, but I think we still need to investigate the contribution of our neighbor. Like, what do these community factors have on bednet ownership? So I want to change gears really quick and spend the last few minutes talking about some of the latest data we have. On this other project. So I want to revisit this story of this neighborhood chemist and why this is important why this access to antimalarial medicine, why this is a concern and importance to us. So we came across when we were mapping this fall and visiting where the locations of some of these drug shops. Our field team came across one store. It's not this one. That they met a gentleman who administers injections. And when asked about the most common antimalarial that he uses, he said he didn't know. And he didn't know because he mixes his antimalarials together and administers an injection. And so he creates a mixture that he thinks his patient needs. And so this kind of highlights this maybe the problem of this interaction, and highlights what is the quality that people receive at a chemist or a private clinic. And almost in kind of this is why it's important. So we began working with the Moy University. They have a health and demographic surveillance system, the DSS, in the Webuye area, in the same Bungoma East district. And this is the study area here. There's 6 sub-locations, which is the smallest administrative unit within Kenya. And so we know that poorer households tend to buy medicine at shops prior to going to a health facility. And so our major concern is this kind of unregulated use of medicines to treat fevers. So we're looking at treatment of fevers for malaria, or treatment of fevers in general. And so the question is, do they get poor care as well at these shops? And so we initially, we were working with the DSS, and we ran the project in 2 phases. And so we began phase 1, working with a small field team. I worked with these guys to collect GPS locations, names, and initial kind of information. It was a census of who's out there, where are they located, in terms of drug shops, private clinics, and public health facilities. And so this is a kind of an initial map of all the locations that they went to. And then phase 2 was a follow-up survey, and we just completed that in December, about mid-December, and just in the last week we've completed the data entry and some of the initial cleaning, and so actually some of this data is new to me, and I haven't. So some of these numbers I'll show you here next are kind of our first look at some of what we've been seeing. And it's neat for me because we've been working on this and kind of seeing this data come to life as we've been out there collecting it, and now it's on paper, and it's interesting and on maps. And so one question we wanted to answer was how close do people live to these private retail outlets compared to the public facilities. And so we see that the average distance to the nearest medicine retailer was about 1 kilometer from each household. And the average distance to the nearest public health facility was about twice as long, 2 kilometers. And the nearest type so there are about 10,000 households in the DSS. So nearly half were closest to a drug shop or a medicine outlet. And then another quarter were closest to a private clinic, and then a dispensary over the next. So in terms of phase 2, we ran a more detailed survey asking about drug availability, provider knowledge, some costs, and so we wanted to kind of investigate and look at quality at these shops. And so we were able to interview nearly every shop. So we surveyed only shops that were selling anti-malarials or had sold anti-malarials in the last 3 months. So we surveyed 96 shops. 80 shops had at least one qualified staff member, self-reported qualification. 39 shops had someone trained on malaria diagnosis and treatment in the last year. Only 3.5% of the drugs were expired, which is interesting and good news. So this is all the good news. And no one was selling chloroquine, which is malaria and is highly resistant to chloroquine. And then only 7 shops were selling artemisinin monotherapies. And so in Kenya, the first-line ACTs are artemether lumefantrine, AL, and so 65 knew of the current first-line drug that was recommended by the MOH, but only 30 of these 65 said 30 of these 65 said that they sold a different type of drug other than the first-line therapy to children under 5 as their first choice. So they said they didn't choose to sell the first-line therapy to children under 5s. Some other bad news.
Question.
Yes.
Did you probe why that is the case? Did you probe why that is the case? I mean, why would they use a different drug for identifying?
No, we didn't ask some more detailed questions on why you chose this. We're kind of just getting a sense of what they do and kind of some of their knowledge and what their dispensing practices. so we didn't ask about that. But that would be an interesting. I think there's a host of follow-up studies and things that could be looked at into some of the details of this. So some other kind of on the bad side was that 23 shops had no one trained, and they were dispensing drugs. Quinine was the most frequently stocked drug across all the shops, and more shops had SP, so sulfadoxine pyrimethamine, which is, has been determined to be somewhat, malaria has been determined in Kenya to be somewhat resistant to SP, and then so they have more shops sold than AL, which is the first line ACT. We also wanted to look at diagnostic testing, and so we see that only 2 shops had ever sold RDTs, with only 1 having them made available. These are just a few pictures that I took when we went to one shop, and the gentleman let me take some pictures of his current stock, and so we can see that there's everything from injections to tablets to oral suspensions out on the market. It was interesting because the private market is very diverse and what's out there. So the other interesting look at this data is in regards to price. Now, the Global Fund, if you're not familiar, have a anti-malarial financing mechanism for a set of countries called AMFM, the Affordable Medicines Facility for Malaria. And in Kenya is one of the 10 or so countries that they're doing this. They just began subsidizing ACTs to flood the private market, and so they just began in August. And in Kenya, Artefan is the procured drug for AMFM subsidization. And so we found we did see some Artefan in the shops, and which is an average of 130 Kenyan shillings, which is about $1.60 per package, which is a course or a dose. Some good news on this side is that the mean price of maybe ineffective or not recommended treatments of artemisinin monotherapies was much higher. But the bad news is that mean price, and this is why more shops sell SP than AL, is because of this price, 40 shillings. And so from what AMFM aims to do is actually subsidize Artefan to get it down to 40 shillings. That's their goal, and so it will be interesting to see how effective this mechanism is in getting this price down to 40 shillings. Yeah. So moving forward, this is just a preliminary look at the data, and so that we wanted to share, but we want to characterize the type of care in terms of drug availability, diagnostic capacity, cost to the patient, and dispensing practices and provider knowledge. And so I think the real goal is to really inform communities, to help them empower and increase awareness about asking for and receiving effective medicines. And so with that, I want to conclude. Well, this is a picture of a community meeting that we had with the DSS and some of the village elders and chiefs and assistant chiefs, and it was interesting, of course. And so I want to conclude and thank Winnie Mira and some of the folks at Moi University, Diana Menya and Andrew Ubala, Chris Simio of the DSS and the DSS team, and most of all the communities of Webuye, so and DGHI as well. So I know this is a lot of information and data and maps, and so I'm happy to answer any questions that you might have. So thank you. Any questions?
How did you choose the number of neighbors and the distance buffer for the number of nets?
Yeah. We're limited with computing power in terms of testing all these different models, and because they take 48 hours to run, some of them, and so we thought kind of logically maybe we thought maybe 10 neighbors would include some of the neighbors that maybe you live with in your compound, if several houses share the same compound. But then also it includes some neighboring compounds. So we thought maybe 10 might be a good number. But then we also wanted to kind of look at it further at the village level, and so we thought maybe 800 meters might be a good estimation. But I think it would be interesting to look at that further and really test out other numbers.
So when you did the distance buffer of 850, was that just an extra 50 from what the village was, or was that an additional 850?
So it was an extra 50 because there was one point that was not included, and so we in the model it said that was inconclusive because there was one point missing, and so we needed to expand the buffer a little bit to include that, and if that makes sense.
It was interesting because they were very similar, the clusters that you had.
Yeah.
But and when I'm thinking back to the density of the different areas that you showed in the first maps, it would be interesting to see. Obviously 10 neighbors is a much greater distance buffer in the less dense areas than it would be in the urban areas. So
yes.
Isn't that interesting to compare those, and instead of doing the distance buffer compared with the number of nearest neighbors would get different results. Instead of 850, you tried incrementally 1,000 and 1,250 or something.
Yep. Yeah. Exactly. So I think love to do that. We're limited on our computing power, and it was funny because I ran some of these and didn't realize it was going to run for 80 hours, and this is my only computer. Can't do anything else. So, any other? Yeah.
Have you looked at associations between malaria burden and bed net ownership, and maybe even some of the private medical facilities and their use of antimalarials, and how that's sort of corresponded?
No, and we haven't in this area, and I haven't read much about other areas, so I'm not sure. What it'd be. I think the other interesting thing that comes from some of this, what's out there, is looking at what percentage of drugs are counterfeit, or what are have their full amount of active chemicals, and kind of look at quality of the actual drug. I think would be another interesting kind of look at what's out there. So we're just looking at brand names and what type of drugs were available. We weren't looking at the quality. So, any other questions? Yeah, that's it.
Have you done anything about utilization? The bed nets, whether they, and I'd also be interested in finding out how they found out whether they own them or it was just a social desirable answer. Did you actually check that they own them, and who uses them?
Yeah.
Because the differences sometimes.
Yeah, for sure. And I think that's one limitation we have with the data that was collected and from what we know that these were self-reported and they weren't confirming whether they were using it or it was the presence of it in the household. And so what we can only say that it might that this is what was reported, and so they might have said, oh yes, I don't have a bed net because I'd like to receive another one, so there's that kind of factor in it. So, but yeah, I think it would be interesting to see ownership and who uses it and number of children per children bed net ratio and things like that. So
because I'm engaged in a program where we actually check for the presence of the net on the bed, and sometimes you actually get a different story.
yeah,
It doesn't always. It's not always what they want.
like they would say they have a bed net, or
They would say that actually it's not there, or
yeah,
it's not being used.
yep,
Or it's probably torn, the condition.
yeah. It's very old, a lot of holes, and yeah, exactly. Or we know that insecticide-treated bed nets are so much better than even untreated bed nets, and so that's a whole other side of it as well.
Yeah.
Yes.
I was just curious about that. In that particular area, do you have statistics on what percentage actually died from malaria?
I don't know. I'm trying to think if we had any type of mortality in terms of like under 5 mortality of malaria. I'm not sure.
For this town, for the region, or for Kenya?
For the region it was studied, because it just seems like awareness of malaria might also be a factor in terms of whether you're getting treatment or
Yeah.
when it's
Not for Webuye. I know for the country, but I don't know specific stats for Webuye.
Yeah, I'm not sure.
That area was a particularly prone area because of
It's lower in elevation near the lake, which is highly endemic, and this information we do know is that roughly 20% of health facility visits, were from malaria, and I know malaria is a major cause of under 5 mortality, and I want to say 80% of deaths due to malaria are in children under 5.
How do they diagnose malaria in the public health sector?
Yeah, that's another.
Is it the right disease or?
No, so it's microscopic testing, so laboratory.
Possibly, or clinical diagnosis. Or
Yeah.
symptomatic.
A good question is in Kenya it's a presumptive, or it has been a presumptive treatment. I think they're trying to more go towards laboratory confirmation. But in outside of the health sector, any type of fever is treated with an anti-malarial. So I think
The last
it's
study I
hard to
read was
understand.
there's some variance, but between 70 and 80% of childhood fevers are misdiagnosed as malaria.
Yeah. And Andrea is actually going there this summer to work with Wendy and look at some RDTs and feasibility. So she'll be joining that area soon and learning more about it as well. Are there any other questions? If you have, we can talk to me afterwards. If you want to ask anything else. So thank you guys.